introduction gets completed, right? Rajan Vaidya sir, you will have to unmute whenever you speak. So that you have to control by yourself.
It will be Dr. Sonal first, then Dr. Chaitanya, and lastly will be me.
Right, sir. Right.
Yeah.
So I'll announce the opening. Good afternoon and welcome everyone. Thank you for joining us for today's webinar. My name is Dr. Amit Borse. I am a senior product manager with IVA, a division of MQR Pharmaceuticals Limited, a pioneer in the field of gynecology and IVF. We at MQR are on a mission to nurture and support 28 days with programming 28, which is the foundation of ART. Programming 28 is based on the concept of ovarian cycle and uterine cycle, managing the same with exogenously given GnRH analogs, gonadotropins, and hormones as per different protocols. MQR promises to deliver all possible support in terms of therapeutic agents and academic support like this. At this time, when we are in a complete lockdown due to outbreak of COVID, with the help of this beautiful technology, we have tried to get the doctors together and continue with academics. Today, we are fortunate enough to have very distinguished speakers with us, experts who will guide us on the topic. We have with us Dr. Sonal Panchal ma'am. She'll be guiding us on the topic diagnosis of PCO and PCO by USG. We have Dr. Chaitanya Naguri sir with us, who will be guiding us on the topic ovulation induction in PCO. And we also have with us Dr. Rajan Vaidya sir, who will be guiding us on the topic PCO and assisted reproductive techniques. I know all the speakers don't need any introduction, but still for the protocol to be followed, Dr. Sonal Panchal ma'am is a consultant sonography specialist with Dr. Naguri Institute of Infertility and IVF, Ahmedabad. She has been a faculty and professor and directors for many institutes and national international conferences. She has published several papers, and she also is a national advisory board member of International Journal of Infertility and Fetal Medicine. If we speak about Dr. Chaitanya Naguri sir, he's been practicing infertility since 27 years. He's also co-director at Ian Donald Inter-University School of Medical Ultrasound at Ahmedabad. He is the pioneer in ART. He has more than 10,000 pregnancies. He has helped more than 10,000 patients in cases of infertility. He also has many publications in national and international journals. He has authored and contributed to several books. He has a huge alumni base of more than 800 students. If we also have with us Dr. Rajan Vaidya sir, honorary consultant and head of department of assisted reproduction, now Navrozji Wadia IVF Center, Parel, Mumbai. He has many membership and affiliations to himself, as you can see. He has been a peer reviewer of Journal of Human Reproduction and Embryology, official issue publication, Oxford, UK. And we are indeed privileged to have such distinguished speakers with us. May I now request Dr. Sonal Panchal ma'am to take over the session, and please share your PPT.
Hi friends.
Yes ma'am, we can hear you.
Yes, I will start in a second.
Yeah. In the meantime, to all the delegates who are with us, almost 300 now, please share your questions into chat box. A question and answer session will be taken after all the 3 PPTs have been done.
So can I start, Amit?
Please, ma'am, please.
Good afternoon, friends. It's really a pleasure to talk to you all. And thanks to MQR and Amit and Amardeep for inviting us here. I'm going to talk on diagnosis of PCO by ultrasound. Amit, I cannot go forward. Yeah. So according to ESHRE ASRM consensus definition of PCOS, 2003, we all know that when a patient has 2 of the 3 criteria, excluding the other etiologies for the same, and this criteria are oligo and or anovulation, hyperandrogenism, and polycystic ovaries on ultrasound. So when two of these three are present, the patient is known to have a polycystic ovarian syndrome. When we say polycystic ovaries on ultrasound, according to the criteria, a polycystic ovary on ultrasound is an ovary which is 10 cc in volume and or has more than 12 follicles according to the criteria defined in 2003. But according to the new amendment that came in ESHRE 2018, this number 12 has been changed to 20. That means an ovary which is 10 cc in volume and or has 20 follicles in each ovary is an ovary which is called a polycystic ovary on ultrasound. But we know that the patient may have two of the three features, and therefore there can be four different phenotypes. Type A would be where the patient has all the three features: hyperandrogenism, oligoanovulation, and polycystic ovaries on ultrasound. Whereas type B is a pure clinical phenotype where the patient has hyperandrogenism and chronic anovulation. Type C, where the patient has hyperandrogenism and polycystic ovaries on ultrasound, and type D is when the patient has oligoanovulation and polycystic ovaries on ultrasound. That means for at least 3 phenotypes out of 4 polycystic ovaries on ultrasound, the confirmation of polycystic ovaries on ultrasound is essential. In spite of this, there is a lot of confusion and overlap in the diagnosis of PCO and PCOS both. And why is that so? Let us reanalyze our know-how. Considering the Rotterdam criteria for ultrasound diagnosis of PCO, the first feature, the ovarian volume or the ovarian diameter, as it was said earlier. A single longest diameter of more than 3.5 centimeters is a large ovary and may be a polycystic ovary, whereas an ovary which is more than 10 cc in volume is also, according to definition, a polycystic ovary. The studies which came out, which were published soon after the 2003 Rotterdam criteria, they did support the finding, and they say that there was a good correlation between the ultrasound diagnosis of polycystic morphology and histopathological criteria for the polycystic ovaries. But in 2006, a study came up which said that the current criteria of more than 10 cc volume would fail to identify a group of ovulatory normoandrogenic women still at a risk of complications associated with PCOS, such as OHSS, ovarian hyperstimulation syndrome, failed implantation, miscarriages, and hyperinsulinemia. Another paper around same time by Professor Kupasik said that an ovarian volume of 6.6 cc also had 91% sensitivity and specificity for the diagnosis of PCOS. And she also mentioned that at least 20% of the PCOS patients have normal size of the ovaries, which may be around 6.6 cc or even lesser. Still one more paper by Junad et al. They suggested that lowering the ovarian volume to 7 cc has allowed 67.5% sensitivity, but a really high specificity, 91.2% for PCOS. And according to that study, the normal ovarian volume was only 4.5 cc. This means that the volume of the ovary, if it is 10 cc on ultrasound, ovary can be said to be polycystic. But even if it is small, it may be polycystic. Remember, the volume is best assessed by a 3D ultrasound and vocal, but you can also calculate the volume by the 3 orthogonal diameters. When you locate the ovary, it is very important to first rotate your probe and find out the longest axis and the longest diameter of the ovary. Take the longest diameter the AP diameter is the longest diameter perpendicular to the longest diameter. Then rotate your probe 90 degrees without any other movement, and the side-to-side diameter is your transverse diameter. So if we say longitudinal diameter as X, AP as Y, and width as Z, X into Y into Z into 0.523 will calculate the volume. Coming to the second feature, the antral follicle count. 12, even when that was the number earlier for the follicular size of 2 to 9 millimeters, the studies which came up soon after the 2003 Rotterdam criteria, they said that setting the threshold at 12 for 2 to 9 millimeter follicular number per ovary offered the best compromise between the specificity 99% and sensitivity 75%. But in 2011, a study came up which showed that the FNPO should be changed, the follicular number per ovary should be changed to 19 instead of 12, and that had a sensitivity of 81% and a specificity of 92%. You can add AMH more than 35 picomole per liter, with this increasing the sensitivity to 92% and specificity to 97%. Does it mean that the morphology of the polycystic ovary is changing? No, it has been clearly mentioned that this change in the threshold is because we are getting new scanners now which are highly sensitive, and therefore we are also identifying the follicles smaller than 2 millimeters. But that was not it. In 2013, another paper came up which said that an average value of 26 or more follicles per ovary is a reliable threshold for detecting the polycystic ovaries in women with frank manifestation of PCOS. And this had a sensitivity and specificity for the diagnosis of PCOS for follicular number of 26. The sensitivity was as high as 85% and specificity as high as 24%. And this was even more than the ovarian volume of 10 cc, which was 81% and 84% respectively. That means single ovary, if it has more than 26 follicles, then the patient is a PCOS. But that is not the cutoff. The same study has quoted very importantly that a lower follicular threshold may be required to detect the milder variants of the syndrome. That means if follicular number per ovary is 26, whatever the size, the ovary may be polycystic, but if it is lower, it may still be polycystic. That means we do not know the lower thresholds for the size as well as the antral follicles. Moreover, multiple follicles are also seen in adolescent girls normally, and they are not all polycystic ovaries. And when the females with polycystic ovaries age, then the follicle number and the size of the ovary decreases. Does this mean PCOS is cured? PCOS is a genetic basis. It cannot cure with the age. It can manifest or not manifest, but the disease, the syndrome is there. The lower thresholds should be defined for the diagnosis of PCOS as age advances, and the same thresholds cannot fit to all the age groups. And this was a landmark paper which came in 2017 September in Fertile Sterile. This paper actually defined different thresholds of volume as well as the antral follicle count for different age groups, though this was a small pilot study, and therefore more studies are required to find out the true thresholds. The ASHRAE 2018 consensus and the new amendment also said that the threshold for the polycystic ovarian morphology should be revised regularly with the advancing ultrasound technology, and the age-specific cutoffs for the polycystic ovarian morphology should be defined. They have also specified that when you want to use these thresholds for the diagnosis of polycystic ovary by ultrasound,
you must do a transvaginal scan with a high frequency at least 8 megahertz. And the polycystic ovarian morphology threshold should be seen in either ovary. But they have also emphasized that this criteria should not be used. That means the ultrasound criteria should not be used as one of the two criteria to diagnose PCOS. That means if the patient is less than 8 years of gynecological age, 8 years past menarche, you cannot use ultrasound as one of the two criteria to diagnose PCOS. This means these patients must have all the three criteria: the oligo or anovulation, the hyperandrogenism, biochemical or clinical, and the polycystic ovaries on ultrasound, and only then you can tell these patients are polycystic ovarian syndrome patients. That means the overdiagnosis of adolescent PCOS has to be controlled. Moreover, there's a variation in the size and the antral follicles count with different ethnicities also. And there's still one dilemma, and that is the variable follicular arrangement, generalized distribution in some patients, whereas peripheral distribution of the follicles in others. And then still one more dilemma, and that is if we think about the original description of PCOS, Sten and Leventhal described these ovaries as glistering and sclerosistic ovaries, meaning these ovaries have more antral follicles, but they also have an excess stroma, which is important. And unfortunately, this feature has been totally forgotten in the present definition. But there are studies that have shown that the polycystic ovarian morphology has been found to be a bit better discriminator than the ovarian volume between the polycystic ovarian syndrome and the controlled women. And this morphology is stroma, what they meant in this paper. To identify the milder forms of PCOS, further information, particularly about the ovarian stroma and the degree of vascularization, is required. Then let's understand why. It is known that the polycystic ovarian syndrome is not a cause, but a result of chronic anovulation. It is a process of evolution from adolescent-aged multicystic ovaries to polycystic ovaries. Then why do we see the multicystic ovaries in the adolescents? Because during the pubertal transition, adolescents have relative androgenemia, insulin resistance, cystic ovaries, and anovulatory cycles. And this transition into the estrogenic state as the puberty comes and the age advances. But in the females with a genetic predisposition to polycystic ovarian syndrome, where there is a high androgen state, it is because of this high androgen that there is more recruitment of the follicles from pre-antrals to antrals. And these more follicles lead to the ovary, which shows several follicles more than 20 in number per ovary. But under the effect of androgen alone, these follicles cannot grow beyond the size of 6 to 7 millimeters. Beyond this, they develop FSH receptors and they lose their sensitivity to androgen. These small follicles do secrete estrogen, and therefore higher cumulative estrogen levels, they cause a negative feedback to FSH, and the FSH rise is dampened. The follicles have become sensitive to FSH, and the FSH rise is dampened. Therefore, there is a slow growth of the follicles, and therefore these patients may have longer cycles. But the estrogen level also increases because of conversion of excess androgen to estrogen by aromatization. If the total estrogen level rises equivalent to that of one mature follicle, which is 150 to 200 picogram per ml, even when there is no mature follicle or there is no dominant follicle, the FSH gets a total negative feedback and NH gets a positive feedback. And because of that, these follicles which have become FSH sensitive or dependent will not grow and undergo atresia. Under the effect of LH, the granulosa cells of the atretic follicles, they become thicker cells, and these are the main component of the stroma. That means with each anovulatory cycle, there is an increase in the theca cell content, which means there is an increase in the stroma. This stroma, where does it go? The theca cells, they try to pack themselves more densely in certain parts of the stroma, and therefore initially some parts of the stroma, they become hyperechoic because of the denser tissue, and that is the first sign to tell us that there is a stromal abundance. When the theca cells further increase, gradually the entire stroma becomes hyperechoic, and beyond that, if the stroma increases, the disease process continues in the presence of altered insulin metabolism. That is when the ovary either grows in size or pushes the follicles to the periphery. One of the two things occurs first and the second follows. That means you may have a variable size of the ovaries, you may have different distributions of the follicles, but it is the stromal abundance which is almost always there when you have a patient with a polycystic ovarian syndrome. And this is potentiated by the study which says that the patients having long-standing PCOS and long-standing anovulation have more dense stroma, and this is a cardinal feature that has been shown as a presence of bright, highly echogenic stroma on the transvaginal ultrasound. The echogenicity of the stroma is always compared to that of the normal myometrium. The stromal echogenicity in normal women are not morphological variant of normal ovaries, but they rather represent a functional entity, a silent form of PCOS, for which the serum AMH also can be added as a best marker. But I would like to specify here that the new amendment that has come in ESHRE 2018 for the PCOS, they say that AMH is not to be used as a diagnostic marker for PCOS. Stromal hypertrophy was recognized as a frequent and a specific feature in ovarian androgenic dysfunction, and stromal abundance and echogenicity is one of the major features that discriminates between the polycystic and the multicystic ovaries. A multicystic ovary has multiple follicles, but they are variable in size, and they do not have a hyperechoic stroma against hyperechoic stroma and almost uniform size of the follicles in the polycystic ovaries. The stromal predominance, as has been discussed already, can be established by the hyperechogenicity of the stroma, but hyperechogenicity is very subjective, not only with the operator, but also with the equipment settings. Stromal assessment can be more objective if we can measure the stromal area or the stromal volume. The stromal area can be measured on 2D ultrasound. Having located the ovary and found the longest axis of the ovary, when you draw a circumference around the ovary, the machine calculates the area for you, and an ovarian area of 5.5 centimeters square has 93% sensitivity and 91% specificity for the diagnosis of polycystic ovary. But this is a surrogate for the total stromal area. So you can deduct the follicular areas from the total stromal areas and the total ovarian area, and that will give you a total stromal area. And the stromal area of 4.6 centimeters square has 91% sensitivity and 86% specificity for the diagnosis of PCO. But there was a paper which was even more interesting and impressive. And that said that instead of measuring or taking into consideration the individual parameter, a stromal area or ovarian area, if you take a ratio of the stromal area to the ovarian area and you take a cutoff of 0.34, it has 100% sensitivity and specificity for the diagnosis of PCO. Though this was a very small patient cohort, another study, multicentric study, was taken up on the same theme, and that also agreed upon the technique. They redefined the criteria of the stromal area to the ovarian area ratio to 0.32, and they said this was the best cutoff. But we know that ovary is a three-dimensional structure, and therefore the 3D ultrasound has the potential to address these points and improve the sensitivity and specificity of the ultrasound in the diagnosis of PCOS. Both total ovarian volume and the stromal volume during the early follicular phase are significantly higher in the patients with PCOS. The stromal volume was positively correlated with the serum androstenedione concentrations in the patients with polycystic ovarian syndrome. The ratio of the stromal area to the ovarian area has the strongest correlation with androgens, testosterone and androstenedione, and also with insulin, according to another paper. And according to the third paper, the statistical significant relationship was reported between the ovarian volume and the stromal echogenicity and serum, with serum LH, testosterone, and a degree of insulin resistance. That means all the three major biochemical derangements, which includes the androgen, which in LH, and the insulin resistance, can all be correlated with the stromal abundance, which means that stromal abundance is a very important feature. We also, in one of our papers, have established that the stromal volume has a strong correlation with the insulin levels, both fasting and PP, and therefore higher the stromal volume indicates insulin resistance in a patient. It has already been discussed that insulin augments LH-stimulated androgen production by the stromal cells. Androgen in turn causes proliferation of the stromal and the theca cells, and this leads to increased in stroma. If we make it simple, it is insulin, which leads to hyperandrogenism. More follicles recruited, so higher estrogen. Higher estrogen, so early rise in LH, so atresia of the follicles and conversion of the granulosa cells to theca cells. Theca cells, which is the main component of the stroma, they produce more androgen, and the entire vicious circle goes on. Can ultrasound explain us excuse me, about the variable response of the polycystic ovary to the ovarian stimulation? It is observed that ovarian stromal PSV after pituitary suppression is predictive of ovarian responsiveness and the outcome of IVF treatment. Measurement of the ovarian stromal area in the early follicular phase is related to the subsequent ovarian response in IVF treatment. Does this work for PCO also? Yes, of course. PCO patients, though on 2D, excuse me please, on 2D power Doppler, it was not possible to show that the PCO ovaries have more blood flows, but on 3D, it was clearly established that the VI, FI, and the VFI, which are the 3D power Doppler parameters, were higher in PCO patients as compared to the non-PCO patients. And these parameters are calculated by the 3D power Doppler. But the vascularity can be variable. The hyperinsulinemic patients, the hyperandrogenic patients have more vascularity, but the obese patients have lesser vascularity. In overweight patients, hyperinsulinemia may be proposed as the uniting factor between the increased vascular resistance, obesity, lipid abnormalities, and cardiovascular disease. This is because of VEGF, but it is also because of LH levels. LH leads to more vascularity because of neoangiogenesis and lower resistance flow because of catecholinergic stimulation and leukocyte and cytokine activation. Therefore, higher the LH, lower is the resistance in the intra-ovarian stromal vessels, and therefore the resistance is lower in the peripheral polycystic pattern as compared to the generalized polycystic pattern. The patients with PCOS have an RI of less than 0.58 in their stromal vessels almost always. Though, as discussed, the obese patients have a little higher resistance. So they have a resistance between about 0.55 to 0.58, whereas thin lean PCOS usually have a resistance of lower than 0.5. Why is the risk of OHSS then? Is this predictable? Yes, of course. If the flow in the stroma is more, that means when you load gonadotrophins into the patient's system, more percentage of this drugs flow into the stroma, and therefore, even with lower doses, the ovaries are delivered more gonadotrophins. If more gonadotrophins are delivered, they have a higher risk of going into hyperstimulation. That means if the blood flow to the ovary is more, the patient has a risk of OHSS. Whereas if the blood flow to the ovary is less, the patient would have a resistance to the stimulation. Moreover, the risk of OHSS is also related to the follicular size. Is it important? Is the follicular size important? Yes, of course. The follicular number per ovary in the range of 6 to 9 millimeters was significantly and negatively related to the body mass index and the fasting serum insulin levels. The obese hyperinsulinemic patients, that means, have lesser number of follicles between 6 to 9 millimeters, and they have more follicles between 2 and 6 millimeters. Now, this is a very important concept. Obese patients have lesser flows, they have a higher resistance flow, and they also have more follicles which are less sensitive to FSH, which are the follicles between 2 and 6. We have already discussed that follicles only when they grow beyond 6 millimeters, they develop sensitivity to FSH. That means obese patients have follicles which are not sensitive to FSH, and they also have lower levels of FSH. Therefore, obesity and insulin resistance may enhance follicular access by dysregulation of AMH through the pathway of hyperandrogenemia, but they basically behave as resistant PCOS patients. So anovulation is the only cause of infertility or recurrent abortions in PCOS. Let us look at the endometrium. The chronic anovulation, prolonged exposure to the estrogen, and increased androgen and low progesterone levels. These lead to increased endometrial thickness and out of phase endometrium. And subendometrial and endometrial blood flow is significantly impaired in the women with PCOS who have clinical signs of hyperandrogenism. That means since the progesterone exposure of the endometrium is early, there's a high chance there's going to be an implantation failure. And because of the high resistance in the subendometrial and the endometrial vessels, these endometria do not get sufficient blood supply to support the implanting embryo, and therefore they have recurrent abortions. So that is the risk of PCO with the pregnancy. That means if we summarize the ultrasound features of PCO, they may not have larger ovaries, they may or may not have multiple follicles, but stromal abundance and increased in stromal vascularity is always there. Moreover, the endometrial advancement is often, almost always seen in the patients with PCO, especially when there is ovulation induction done. Though this fact is well understood, methods of high inter-observer reliability to assess the stromal abundance are still awaited. Till then, we have to consider stromal abundance as a consistent feature, but not truly measurable with ultrasound so far. But we can still know the endocrinological milieu just by ultrasound. If you're seeing stromal abundance, it means there is an increased insulin level. If you are seeing more antral follicles and high uterine artery resistance, it indicates more androgen. And if you're seeing more stromal vascularity, it means the LH has started rising, because the rising LH leads to first neoangiogenesis and catecholaminergic stimulation to lead to more vascularity, and in the course of time it leads to follicular atresia and therefore stromal abundance. It is very important that when you report on ultrasound, a polycystic ovary on ultrasound, you must mention the last menstrual period. That means you must mention which day of the cycle you are doing the scan, because these scans are essentially done only on day 2 or 3 of the cycle. You cannot diagnose PCO at any time unless the patient is totally anovulatory, where a scan done on any day should be good. The scan route should be always transvaginal with an 8 megahertz frequency or a higher frequency probe. You must mention the antral follicle count. You must mention the 3 orthogonal diameters and the volume of the ovary, and the way that you have calculated the volume, whether it is by 2D or 3D. You must mention the endometrial thickness and the morphology. You must mention about any pathology in the endometrium if it's present. And you must also mention about any ovarian pathologies or the corpus luteum which is present. If the corpus luteum or a follicular cyst is present, then the volume of the ovary will not be taken into consideration. Thank you very much.
Thank you, ma'am. Thank you for your time and your presentation. May I now request Dr. Chaitanya sir to please take over?
Just before he starts, I have a request. There are a few people who can still not log in. Amit, if you can help them.
Ma'am, I'll share. How do I share my number to them? Because
you can forward it to me. I'll forward it to them. Please.
I'll put it into chat box. I'll put it into chat box.
Please do that. Thank you so much.
Yeah. Ma'am, I shared my number. If you can just pass on, I will speak to them. What is the problem?
Thank you so much.
Yeah.
I will just share sir's presentation.
Please, ma'am. Great.
Good afternoon, friends. At the outset, I'm thankful to MCure for inviting us for this webinar. I'll be discussing on ovulation induction and PCOS. You have already known what is the value of a stromal volume, and that is very helpful as far as the diagnosis of PCO is concerned. But those who are not having the sophisticated ultrasound, and perhaps they may have to rely on this 2 hours glucose tolerance test, where you take a fasting glucose level, give 75 grams of glucose, and after 2 hours you can measure, you can diagnose a frank diabetic patient. But to your great surprise, who are not diabetic but who are having an insulin resistance, after 2 hours of 75 grams of glucose, you see a spike of insulin level that may reach more than 151 to 300 or even more than 300. So these are the classical cases of polycystic ovarian disease. These are the cases where your ovarian drilling will help you a lot. So that's why those who are not having a 3D ultrasound can definitely go for this test and can diagnose the PCOS. Now let us consider the ovulation induction and PCO. We have weight loss, clomiphene, letrozole, insulin sensitizers, glucocorticoids, gonadotropin, GnRH antagonist, GnRH agonist, ovarian drilling, and Rajan is going to talk on IVF and IVM. Let us consider one by one. The weight loss, that is always the first line of treatment, and joint efforts are necessary. The important thing is that when there is a weight loss, there is 5 to 10% of the weight loss is important, and that reduces 30% of the visceral fat due to increased lipolysis and high metabolic activity. And that can produce the reproductive function to 60 to 100%. So It's not necessary to tell the patient that you go and reduce 10 kg body weight and come once again. The patient will go to your neighbor, and we have found that the most difficult job in the world is to lose the weight. So you can emphasize this very well, but don't rely it on completely. You can start the treatment also. But if you don't start the treatment, that in our private practice, the patient will go to somebody else. Now, this is a very good NHS scheme. If you see in UK, they have decided that no funding is done to the patient when the BMI is more than 30. If something like this is done in an insurance company, perhaps that will be very good, and they will encourage them to lose the weight. All the studies have shown the higher recovery of the oocytes, but the lower fertilization rate with the high abortion rates. Obesity drives polycystic ovaries to be more clinically manifest. That is, an occult PCO to clinical PCO is same. But the woman in a normal weight may not benefit by a weight loss. PCOS does not cause obesity. This is a wrong notion. In the very popular, people know that my weight is more only because of PCOS. It is the other way around. Anti-obesity agents, it is considered as an experimental therapy and too uncertain to advocate as fertility therapy. So don't advise for anti-obesity drugs. These are international evidence-based guidelines of 2018. Same way for bariatric surgery, it is still considered as an experimental therapy. Only when the BMI is more than 50 kg per meter square, then it is the first line of treatment. And when you go for bariatric surgery, the pregnancy is avoided for 12 months and nutritional deficiencies are very common. Second is a clomiphene citrate. Whether you give 50 to 100 milligrams should be the maximum dose. It can be given from day 2, day 3, day 4, day 5. The pregnancy rates are same, but particularly for a PCO patient, never start from day 2. You will get multiple follicles, but you should always start from day 5. And more than 100 milligram has got less than 10% of the pregnancy rates, and that's why you should never increase that dose. Now, those who are using clomiphene citrate must remember that 8 or 9 LH level should be done. It's a PCO patient, and when the FSH and LH rises because of clomiphene citrate, the LH is more detrimental, and particularly in a PCO, when LH is more than 10 international unit, it reduces the conception rate and increases the abortion rates. Now, clomiphene is preferred over metformin when the BMI is more than 30, and clomiphene is combined with metformin only when the BMI is more than 30 kg per meter square. Otherwise, it has got no role. Now, clomiphene versus clomiphene plus gonadotropin, very popularly given by so many consultants, that they start with clomiphene from day 6, and from day 6 onwards, they normally start the gonadotropin to the patient. They have insufficient evidence whether one intervention is better than the other, and that's why don't waste your money by combining clomiphene with gonadotropin. And clomiphene, when it increases an LH, has already spoiled the quality of an ova, and that's why by adding a gonadotropin to this patient, you cannot improve the quality of an ova, and that's why this combination is useless as far as the PCOS are concerned. Third one is a letrozole. The letrozole should be considered as the first line pharmacological treatment for ovulation induction with PCO with an ovulatory infertility. And this is the international evidence-based guideline of 2018. And that's why now clomiphene is not at all used as a first line of treatment. As far as PCO is concerned, always start with the letrozole rather than clomiphene citrate. Now, the mechanism of letrozole is it causes an hypoestrogenism. And second is the temporary rise of the testosterone. Now, this hypoestrogenism allows the FSH and LH to rise, and this will develop a follicle. Follicle will secrete the estrogen. Estrogen will go back to the hypothalamus and will decrease the LH and FSH because the receptors are not occupied by letrozole. While in clomiphene, they are occupied by letrozole. So, in spite of high estrogen, there is high FSH and LH. While with letrozole, the high FSH and LH will decrease. And second, the main advantage of it is that there is a temporary rise of testosterone. Testosterone is not converted into an estrogen because of no aromatization, and that's why testosterone level will rise. And this testosterone stimulates the follicle to the gonadotropin. The enter follicle counts are stimulated, and that's why the sensitivity of the follicle is increased to gonadotropin, and lesser doses of gonadotropins are required. And that's why letrozole plus gonadotropin is one of the best combination, while clomiphene plus gonadotropin is a hopeless combination. So advantage of letrozole is monofollicular development, less multiple pregnancy rate, reduced chances of OHSS, and letrozole resistance is less than the clomiphene resistance. Pregnancy rate is increased by 40 to 60%. These are the internationally evidence-based guideline 2018 with letrozole as compared to the clomiphene cited, and that's why the letrozole is considered as the first line of treatment. And letrozole improves the implantation. If you see the latest figures that letrozole is given for 2 months in the cases of endometriosis, and that will improve the progesterone resistance, and the implantation rates are improved. So in an endometriosis, you can give letrozole for 2 months and that will be very useful. Now, there are other regime like extended letrozole therapy. 2.5 milligram letrozole is given for day 1 for 10 days in CC resistant PCOS patient, and they may produce more follicles and may give a better pregnancy rate. And there is another step of protocol, 1, 2, 3, 4 tablets of 2.5 milligram of letrozole is given respectively from day 2, day 3, day 4, and day 5. And people say that it increases. But I'm deadly against this, both the protocols, because your purpose of giving a letrozole is monofollicular development. And when you give a letrozole for a longer time, there will be more and more LH will be secreted. And this LH is detrimental to an ova. So all the advantages that you get by giving letrozole for only 5 days are abolished completely when it is given as an extended therapy. And if you consider the cost of so many letrozole in a cycle as compared to clomiphene, I think it is more than 10 to 15 times the cost is higher. And therefore, the larger and more robust studies are required to accept this protocol, and it cannot be used in a routine practice. Fourth are the insulin sensitizers. Insulin sensitizers decreases the hyperandrogenism even in a non-obese patient. So it corrects an abnormal insulin action by decreasing the insulin level. But the meta-analysis, Lagro and Moll, this is the largest series in the world which has been published, that says that the metformin monotherapy has a lower pregnancy rate as compared to clomiphene cited. And these all two randomized studies indicate that it does not increase the live birth rate. So metformin is not better than the placebo for the pregnancy rate, the multiple pregnancy or the abortion rate. So at least I suggest that those who are using metformin to all the PCO patients, international evidence-based guideline 2018 says that it is of no use. It does not increase the pregnancy rate. In only those patients who are CC resistant, you may add in metformin, but still the pregnancy rates are very poor. You should switch over to gonadotropin, or you should switch over to letrozole plus gonadotropin, rather than going for this therapy, because they are wasting your months. And in our prior practice, patients are always limited number of months who is going to stay with you. So if you don't give the pregnancy, don't give them the pregnancy, they are going to shift to the other consultant. So the metformin is normally given to those patients who don't want to conceive immediately. Those who want to, or those who have come for some other purpose to a gynecologist, then they are the best patients, because it normalizes the normal homeostasis is established, and then when the patient wants to conceive, the conception is easy. But for infertility, if the patient has come to you, metformin has got no role. Metformin, in addition to lifestyle, could be recommended to an adult PCO for the treatment of weight, hormonal and metabolic derangements when the BMI is more than 25, not for infertility. Addition for metformin plus gonadotropin does not increase the pregnancy rate, and for IVF also it does not. Metformin alternatives, now the insulin sensitizers like pioglitazone, rosiglitazone, ecarbo, they are so popular, D-chiroinositol, but they are not superior to metformin, and metformin has got no place as far as infertility is concerned. So this metformin alternatives have no role as far as the infertility. Even 2018 evidence-based guidelines says that it is still under the experimental therapy, and it still requires a lot of other papers. Future research is required. Then comes the glucocorticoids, one of the marvelous drugs I've observed in the practice, and 50% of PCOs have an adrenal component in an hyperandrogenism. Here dexamethasone is given 0.5 milligram daily, that improves the response, and lower doses of CC as well as the gonadotropin or the letrozole is required. It is useful in obese CCO resistant PCOs. It is very common. Then comes the gonadotropin, and gonadotropin is a second line of treatment. The first is letrozole, second is the gonadotropin, which are given for PCOS who have failed the first oral ovulations. It can be considered as the first line of treatment in patients of ultrasound monitoring after counseling for the cost. Multiple pregnancy should be discussed with the patient. Now, gonadotropins are preferred over clomiphene plus metformin in a CC-resistant anovulatory cycle. Gonadotropin should be combined with metformin in a resistant cases. Either gonadotropin or ovarian drilling should be used after counseling. So either you can go for gonadotropin or you can go for an ovarian drilling. These both are the second line of treatment. So those patients who cannot afford a gonadotropin therapy, you can do an ovarian drilling, ask the patient to go home, and within few months they will come with the pregnancy to you. Which gonadotropin? There is always a dilemma, which gonadotropin, and every second or third month you find a new company who has come with the gonadotropin. So what is the physiology? If you consider the bioactivity of the FSH after the menstruation, the bioactivity is very poor and the amount is very much. But if you consider the pre-ovulatory FSH, the bioactivity is highest and the amount which is secreted by nature is very less. So the recombinant FSH, which is prepared from Chinese larva, which is cloned in such a way that it mimics the peri-ovulatory FSH. And that is why the dose of recombinant FSH required is always less as compared to the urinary FSH, which is always prepared from the menopausal urine, which is the least bioactive. That's why if you are using a recombinant FSH, your dose will be less. But if you are using a highly purified FSH to this patient, then it is almost double the dose is required to stimulate the patient. If you see the bioactivity of HMG, it is 8 international unit, while recombinant FSH, it has 10,000 international unit. With highly purified FSH, it has got a 9,000 international unit per milligram of protein. So either you should use for FSH highly purified or you should go for the recombinant FSH. I would like to warn to many consultants who are normally using HMG for the stimulation protocol. Now, in a PCO patient, the LH level is already high. And by adding HMG to these patients, you are adding more LH to this patient. And that is why it is detrimental to an OVA. There are thousands of papers which have said that the FSH is always better than HMG as far as the PCO patients are concerned. Because endogenous LH is already present, you have not down-regulated the patient. And that is why there is no need of adding an extra LH which is present in HMG. Now, there are a lot of papers where recombinant FSH over HMG, even the FUNET, even in 24,000 ART cycles have proved that recombinant FSH is always better in PCO than HMG. Now, when you want to give in an IUI cycle, you must restrict to only chronic low dose protocol because your diagnosis is PCO. That's why you start with 75 international unit from day 5. Always start in an IUI cycle, the injections from day 5 only, and that is from day 5. You give it for 14 days. It is very difficult to resist ourselves not to increase the dose. So many people after 5 or 7 days, when they don't get a follicle, they immediately increase the dose, but that is not required. Here you can give it for 14 days to this patient. And if the follicle does not develop, then you can increase the dose to 37.5 international unit and give it for 7 days. In more than 95% of cases, you will get a very good follicle. Either you will get only 1 or 2 follicles, and the pregnancy rates will be very good. In a PCO, the pregnancy rates are poor because of multiple follicles, because the implantation rates are poor because of high estrogen and high progesterone. Here in a chronic low dose protocol, the E2 level is not high, progesterone level is not high, and that's why the implantation is very good. Believe me, this is an excellent protocol in an IUI. IVF is always a third line of treatment. PCO is never an indication of IVF. PCO is an indication for IUI. And if you go with a chronic low dose protocol, your pregnancy rates will be very good. Only thing you have to keep it in mind that don't increase the dose unnecessarily, particularly when you don't get a follicle. Give it for 14 days, then and then you increase the dose. And if you see that the rate of OHS is extremely low, and rate of multiple pregnancy is also extremely low, particularly when you go for chronic low dose protocol. Now, one of the excellent paper, and this was the paper by Professor Roy Hamburg, that instead of using a clomiphene citrate, straight away go for FSH. And if you go for FSH as a first line of treatment, rather than clomiphene or rather than letrozole, then you get a double the pregnancy rate. When this paper was with clomiphene, and you get almost double the pregnancy rate when straightway the FSH is used. And that is why you can straightway go for clear, there is a clear superiority of the low dose FSH over CC as a first line of treatment, and chances of clinical pregnancy in the first cycle is 30% as compared to 14.6%. After second cycle, it is 50%. So shorter time interval is required for the pregnancy time. Those who are doing an IUI, please, in all PCO patients, always go with gonadotropin cycle and then do an IUI. You will get an excellent pregnancy rate. So what you can see with the clomiphene, there may be an ease of administration. The cost may be less, but if you see the monitoring is required in both the things. Treatment for pregnancy time is shorter. Chances of pregnancies are very high, and single live birth is very high with the FSH. That's why I always prefer with the low dose FSH which is required. Now, I already told you that gonadotropin plus letrozole is an excellent, because you give letrozole from day 3 to 7, and by 7 the estrogen level is high. That goes to the hypothalamus, and then it decreases the FSH and LH secretion from the pituitary. And now the FSH is decreased, and you are adding FSH from outside to rescue that developing follicle. So you get only a single or 1 or 2 follicle, and the pregnancy rates are very high, which are comparable to the gonadotropin therapy. And that's why the with letrozole plus gonadotropin nowadays is one of the excellent protocol as far as the IUI is concerned for the PCO patients. The use of long-acting and daily recombinant FSH is equally recommended in JNRH antagonist cycles. Adjustment of the gonadotropin doses in the med-stimulating phase. So don't try to increase or decrease the gonadotropin. Whatever you are giving, it should be consistent to the patient. Ultrasound-based decision protocol. This is one of our paper which has been published in the journal. And here we have done an ultrasound protocol, that is age, BMI, AFC, ovarian volume, stromal RI and stromal PSV. And then accordingly you give the markings, you give the points, and then accordingly to this protocol, when we get more than 25, then 25 international units should be the starting dose. And when it is 6 to 10, then we start with 150 units for resistant PCO patients. So according to this scoring system, we always do a stimulating protocol, and we never come across any patient of OHSS in an IUI cycles. GnRH antagonist is one of the very good drug, particularly when in a thin, lean PCO patients. In these patients, particularly when the size of the follicle is 14 millimeter, this prevents the LH surge, and pregnancy rate is improved, particularly in a thin, lean PCO patient. But please don't give it to all the patients, because the smaller amount of LH is always required for the final meiosis, and those which are not indicated patients. And if you give antagonist, all of a sudden on the next day you see that the follicle has regressed or the follicle has not grown further. That is, and there is no need to increase the dose of FSH when you are using an antagonist, and it's always used in a thin, lean PCO patients. Then it gives a very good result. Agonist is an established treatment of IVF, but down regulation should never be done in an IUI cycle in a PCO patient, because it increases the cost, OHSS, multiple pregnancy. Instead of that, always go for chronic low dose protocol, which gives a better pregnancy rate than the agonist. Particularly when you get a PCO patient, and sometimes it may happen that all of a sudden, in spite of your best effort, you get the multiple follicles on both the sides. If you go for chronic low dose protocol, it will not happen. But surprisingly, you may have increased the dose when the follicles have not developed. And at that time, if you see, when you see the multiple follicles on both the sides, then give an agonist as a trigger. Use an antagonist and give an agonist as a trigger. And when you give an agonist as a trigger, that causes a high rise of an LHR, that is for final oocyte maturation instead of HCG. Agonist trigger is given. And when agonist trigger is given, then the follicle will rupture after 36 hours. The advantage of agonist trigger is that it causes an FSH surge along with an LH surge. So FSH surge, still its value is not known in the human being. But if you see the animals, then the FSH surge is required. And if FSH surge is absent, there are no pregnancies. And particularly FSH surge is required in our patients of LUF or our patients of endometriosis, where the FSH surge, if it is absent, the ovulation rate is poor. And that's why in all endometriosis, we normally use the agonist trigger that will be very useful to the patient. Now, particularly when you use an agonist, then the luteal phase defect is very common, and you can give a GnRH. Whenever you give GnRH agonist, intensive luteal support is given, or you may give a dual trigger also. That many a times when you give the agonist trigger, the LH level may not rise, and particularly if the patient has taken the oral contraceptives for a long time, then you should add 1000 units of HCG at the time along with an agonist trigger. Or you can give HCG at the time of an IUI. That 1500 units of HCG is given at the time of an IUI. That will rescue the corpus luteum, and luteal phase defect will not occur. Low dose of HCG and luteal phase recombinant LH. These are also the measures that can be done for the luteal support. This is the recent paper that low dose of HCG, that 100 to 150 units of HCG, but unfortunately it is not available in a pen device, and that's why you can give only, this is not possible. Otherwise in future, perhaps when you get a device, a pen particularly for 100 to 150 units you can deliver, that will be a very good luteal support in future. And last will be the ovarian drilling. Ovarian drilling is considered as the second line of therapy. The first line of treatment, when the laparoscopy is indicated, then you should do it as a first line of treatment. Particularly in a thin lean CC resistant PCO, that is very common. Before starting a gonadotropin therapy, you can go so that the dose of gonadotropin can be reduced. In a recurrent pregnancy loss, particularly due to PCO, then also it is a very good therapy. Now, the mechanism is that we have already discussed in an ultrasound lecture that it is the stroma that is responsible for all this damage that is done in PCO patient. So it destroys the stroma. That's why it decreases the androgen production. And when this androgen production is decreased, it decreases an LH level. FSH-LH ratio is automatically reversed, and the spontaneous ovulation is possible. So what is important is the destruction of the stroma. When you destroy the stroma, then and then the spontaneous ovulation is possible. The advantage of ovarian drilling, Howard Jacobs has said that monofollicular development, it outweighs the other methods only because of the single benefit. And that's why the ovarian drilling has given much importance. 12 months of pregnancy rate after ovarian drilling and 6 months of gonadotropin has the same pregnancy rate. 7 to 80% of the ovulation rate with 60% pregnancy rate. And even after several years, the spontaneous pregnancy can occur, and the effect of drilling lasts for 9 years. So please don't repeat it for the second pregnancy if the patient has come for the secondary infertility, and majority of the patient gets always the spontaneous pregnancy after ovarian drilling as far as the second pregnancy is concerned. So the effect of drilling lasts for about 9 years. The contraindication is a PCO-like ovary. Many a times you look, when you put a scope, you feel that it's a PCO-like ovary, and you start drilling, then you may come across an ovarian failure to this patient. So either an ultrasound documentation of PCO or the insulin resistance after 75 grams of the glucose after 2 hours, if the insulin rise occurs, then and then only the ovarian drilling is to be done. Otherwise, ovarian drilling should never be done. There are always a dilemma regarding the number of punctures, how many punctures are to be done. And we have done a paper, and the minimum number of punctures are more than 15 to 20 in a single ovary. And we have almost about 2,500 pregnancies by this time without a single ovarian failure. I would like to emphasize here that if you consider a Steen-Leventhal paper, the Steen-Leventhal had said that larger the ovary, the larger chunk is to be removed. Smaller the ovary, the smaller chunk is. So he has never said categorically that only this much amount of ovarian tissue should be removed, whatever is the size of the ovary. And that is why the number of punctures are always related to the stromal volume, or number of punctures are related to an ovarian volume. If the more the stromal volume, more punctures are required. Lesser the stromal volume, the lesser number of punctures are required. And that is why now this was the paper which we had already published. And if you see that with a drilling, the pregnancy rates are always very high, and particularly the time taken for the pregnancy is also very less. Within 3 months, majority of the patients conceive. we started this from 1994 and we have done this many patients, and I'm very happy that after 2009 the people have started coming up that the ovarian drilling, if your AMH level does not decrease, it is a failure on the part of an ovarian drilling. You do an AMH level, and after ovarian drilling, if the AMH level does not decrease, or your drilling is a failure. And so you have to destroy the stroma. That is why then and then the androgen level will decrease. And there are a lot of papers which have said that according to the stromal volume, the number of punctures are to be done. And 2011 also, then afterwards, a lot of paper came. The number of punctures should always be according to the stromal volume. Then the pregnancy rates will be very good. So my carry-home message is the weight loss is the first line of treatment. Letrozole is a drug of choice. Addition of metformin has no advantage. Glucocorticoids may be useful in a subgroup of the patients. Gonadotropin or the ovarian drilling is the second line of treatment. Chronic low dose FSH protocol is an ultimate protocol. Agonists may be used for ovulation trigger and never for down regulation. Antagonists are very useful in a thin, lean PCO patient. IVF is a third line of treatment, and IVF will be the future, which will be discussed by Rajan. So thank you very much, friends.
Thank you, sir. That was a fantastic presentation by both of you. Yes, there are many questions which we'll be taking soon at the question and answer session. Dr. Rajan Vaidya, sir, I'll be now sharing your presentation.
Okay. Can you put my presentation?
Yes, sir. This it is. Is it visible, sir?
Can start?
Yes, sir, please.
Thank you, Dr. Amit. Good evening, everybody. At the outset, let me thank MQR for inviting all of us to talk to you on this very fascinating topic of PCOD and infertility. With the two superb talks by preceding speakers, the onus is entirely on me to keep up the tempo of this webinar, and I rest assured I'll try to do my best. Amit, just go to the slide number 10, because first 10 slides pertain to definition and ultrasonographic features, which has been already well covered by Dr. Sonal and Dr. Chaitanya. Yeah, this just go further. That's right. The previous one. Yeah. The preval, as Dr. Chaitanya has already stated. The one next to that. One next.
Doctor,
one next. One. That's
yes,
right.
Yes.
Stay there. As Dr. Chaitanya has already stated, IVF is the last option of treatment after all the other treatments have failed and she has not yet conceived. So the incidence, I will be talking to you about IVF and allied procedures and their role and how to optimize the cumulative conception rates, at the same time avoid multiple pregnancies as well as ovarian hyperstimulation syndrome. Almost 30% of the women attending IVF centers have the problems with ovulation, mainly the polycystic ovarian disease. Next slide. Next. So as we already stated, IVF is not the first line of treatment, but IVF is the line of treatment if PCO is associated with other conditions, like say for example, tubal factor, male factor, or the couple has not conceived, the patient has not conceived after 6 cycles of ovulogens. Next slide. Next. You are going back. No, one prior to that. One prior to this. Yeah. No, one prior, Amit, one prior. One prior. One before.
Amit, one before
Yes,
these
sir. Yes,
slides.
sir. Yes,
One
sir.
before.
Yes, sir. It takes a little minute. Is it okay? Treatment modalities?
Treatment, yeah. These treatment modalities, IVF is the last line of treatment. Next. I have included this slide purposely of role of insulin sensitizing agents in PCO and ART. Particularly, I have included many of the questions also which have been repeatedly asked to me during the conferences and as well as by my patients, as well as I have come across during the treatments. Addition of metformin to oral ovulogenics or injectable gonadotropins does not improve ovulation rates, pregnancy rates or live birth rates, as already stated by Dr. Chaitanya. However, its prior treatment, say for 6 to 12 weeks, reduces the incidence of severe OHSS in PCO cases. It does not reduce the incidence of miscarriage rates post-conception. However, it improves impaired glucose tolerance as well as insulin requirements in frank type 2 diabetes mellitus patients and can be safely given right up to the term. Let me tell you that metformin has been advanced about 6 or 7 years back by US FDA from category C to category B, meaning thereby it can be given from the first day of conception right up to delivery and safe to be given. Recent meta-analysis shows metformin does not result in weight reduction. I have come across in my practice, and this has been asked to me in conferences, does metformin lead to weight reduction? I have come across so many young women, young girls brought to me by their mothers, and they have been already prescribed by metformin in the hope that they may cause weight loss. It does not lead to weight loss. It can be administered throughout the body. Next slide. Next slide. The role of other insulin sensitizing agents, absolutely no role for dichloroanisotol and pioglitazone and acarbose. Next slide. Next slide. I will quickly go through the pre-ART workup, which must include age, weight, BMI, and the history of response to previous ovarian stimulation, if at all available. The basic investigations directed to judge the well-being of the patient, which must include the thyroid investigations and serum prolactin to rule out hyperprolactinemia. Very important tests are the tests of ovarian reserve, which are basically two: the anti-Mullerian hormone and the day 2 antral follicle count by transvaginal ultrasound. Anti-Mullerian hormone has the advantage that it can be done on any day of the menstrual cycle. Virtually, it's a walk-in test, and it has the least intercycle or intracycle variability and has a very high predictivity for the ovarian response. Antral follicle count on day 2 performed by transvaginal sonography only has the added advantage that its results are instant and they are cycle specific. So between the two, both have good predictive values. I lay more faith on day 2 antral follicle count. Next slide. Next slide. Ovarian reserve tests are, oh, you've gone further. One before. Yeah. Ovarian, one before, one after. Yeah, stay there. Ovarian reserve tests are important to prognosticate the outcome of the IVF treatment specific to the patient and thereby helping us counseling her regarding her chances of success in the ART procedure. These are also important in formulating the starting dose of gonadotropins, as we'll see later on as we go along the lecture. Next slide. What are the aims of controlled ovarian hyperstimulation in PCOD? Recruit a uniform cohort of follicles, prevent premature release surge, to avoid ovarian hyperstimulation syndrome, most importantly, to get a perfect endometrium. As Dr. Sonal has already stated, endometrial receptor abnormalities are very much known in PCO patients, avoidance of multiple pregnancies, getting optimal pregnancy rate, and in the Indian scenario particularly, be cost effective. Next. Transvaginal sonography monitoring, I am not elaborating in detail because Dr. Sonal has an entire lecture devoted to it. I'll just touch upon it. We do it to estimate the sizes and the number of the developing follicles, to rule out the possibility of multiple follicles developing thereby OHSS, and to monitor the endometrial thickness. Next slide. Now, having decided that she is to be recruited into IVF program, two important questions to be answered: which drug, that is what is the choice of gonadotropin, what is the choice of protocol. Let us go to the choice of gonadotropins. No difference in the outcome between ovarian stimulation by either HMG preparations or urinary FSH or recombinant protocol or recombinant FSH has been proved by many trials, and no significant differences have been observed between HMG, urinary FSH, or recombinant FSH. All are equally effective. Next slide. However, even the Cochrane supports the view that there is nothing to choose between HMG, urinary FSH, or recombinant FSH. However, the FINVAT trial, which Chaitanya stated, as well as meta-analysis conducted by Ganbi and others, it was a prospective randomized control trial that proved that recombinant FSH leads to 20% more likelihood of achieving pregnancy than urinary FSH, and the amount of FSH used was 400 international units lesser. This prospective RCT further proved that the clinical pregnancy rates were 5% higher with recombinant FSH in fresh embryo transfers, whereas 6.4% higher in the frozen cycle transfer. And however, as the choice of FSH preparation is still a individualistic preference, I tell you, I prefer to use recombinant FSH in all cases of potentially high responders, such as PCO cases, and this I can tell you, these recombinant FSH are the only preparations that can be used in time-sensitive situations, which we do a lot for oncofertility, where I start luteal phase stimulation protocols. I would like to use definitely recombinant FSH, and also in dual stimulation protocols where we have no option but to use recombinant FSH. Next slide. There are advances, just as we have advances in the gonadotropies, we have advances in the gonadotropin delivery systems. The use of pen devices is an excellent innovation. These pens can calibrate the dosage of FSH to the fractions of the units. Doses as low as 7.5 milli international units can be given with greatest precautions. More importantly, patients can be educated to calibrate their doses and to self-inject themselves. This has assured a better patient compliance and better assurance in the minds of the doctor that the right dose will be delivered to the patient. Next slide. IVF in PCOS, again I am coming to this slide. We have to prevent premature LH surge, choose the right trigger option, prevent OHSS, and prevent multiple pregnancies. Next slide. Prevention of premature LH surge is achieved by the use of gonadotropin analogs. Mainly, there are two types of analogs, agonists as well as antagonists. Agonists, as we all know, they initially produce the initial stimulation effect followed by blockage of GnRH receptors for long time, whereas GnRH antagonists block the receptors at the pituitary level instantly, and their action is short-lived. Next slide. Therefore, there are basically two types of ovarian stimulation protocols in assisted reproductive technology, namely agonist-based and antagonist-based protocols. Next slide. Agonist-based protocol, to tell you very frankly, I have given up on agonist-based protocols for more than a decade and a half now. I use it not only for high responders, but for normal responders as well as for poor responders. Just for the sake of mentioning, there used to be, in my practice, of course, there are people who still do agonist protocols, long protocol, short protocol, and ultra short protocol. But let me emphasize that PCO patients, antagonist protocol with agonist trigger is the protocol of choice. Next slide. I have mentioned the two protocols here. For the sake of mentioning agonist protocol, we used to start small doses of agonist from day 21, say something like 0.5 milligram every day till she menstruates, and then half the dose of the agonist till the date of trigger. The biggest disadvantage of long or agonist protocols is you have no choice but to use human chorionic gonadotropin or recombinant LH to trigger the ovulation. You cannot do agonist to trigger the ovulation. And as we go along and see further, SCG is the incriminating drug which leads to the genesis of VEGF, as we see later on, which is the molecule incriminated in causing OHSS. Whereas in antagonist protocol, next slide. Antagonist protocol uses GnRH antagonist to prevent premature LH surges. Antagonists are started from day 2 of the spontaneous menstrual cycle or OCP withdrawn period in a PCO patient with oligomeric cycles. There are two types of antagonist protocol, fixed dose and flexible dose. In fixed dose, the antagonists are started on the day 6 of the gonadotropin stimulation, irrespective of the size of the cohort. Whereas in a variable protocol, the antagonist is started when the lead follicle is at 14 millimeter. Going further, I have, or rather many people have a lot of flexibility. I have started antagonists as early as day 2, even when the lead follicle has not reached 14 millimeter, because the number of small intermediate follicles, say about 7 or 8 millimeter, produce estradiol, and this estradiol can give a positive feedback to the pituitary, resulting in the premature surges. And that's why the flexibility is not only at 14 mm, but it could be even lesser depending on the number of follicles which you see intermediate in the ovary. And going further, I start rather all the antagonists on the day 1 of stimulation in my random start stimulation protocols. When I start in the luteal phase, as well as in the dual stimulation protocols, the gonadotropins and the antagonists are given on the same day. Next slide. This is a diagrammatic representation of the antagonist protocol, which I just told you. Next slide. Antagonist versus agonist protocol comparison. Equally effective, both equally effective. No difference in the conception rates, ongoing pregnancy rates, or live birth rates. Much lower consumption of gonadotropins with antagonist protocol when compared to agonist protocol, but a significant reduction in ovarian hyperstimulation syndrome with antagonist protocol. So more patient compliance to GnRH antagonist protocol. Next slide. TV monitoring is mandatory, and we do a baseline scan to see that there are no residual ovarian cysts, as well as that the endometrium is shed away. In normal responders or normal patients, we start the first scan is done on day 7 or so. In PCO patients, we can do first scan on day 3 or day 4, mainly to judge the number and the sizes of the follicles. Next slide. TV USG on the day of trigger, if there are, I think you skipped one slide in between. Anyway, number of mature follicles, if there are more than 20, high risk of OHS is indicated. If there are a number of mature follicles are more than 20, intermediate follicles are between, that is follicles between 10 and 14 are more than 15. Agonist trigger is the only option to trigger ovulation in this particular patient if OHS is to be completely avoided. Agonist trigger, freeze the embryos and transfer the embryos, cryopreserve the embryos, transfer them in the deferred cycle is the surest way to achieve 0% OHSS. Next slide. Yeah, it is there. I do not do hormone investigations. I rely very heavily on my sonography findings, but to mention, the incidence of ovarian hyperstimulation syndrome is about, once the E2 level crosses 3,500 picogram per ml, is given to be around 2%. In as well as, but when you give an agonist trigger and we do not transfer, this is incidence of ovarian hyperstimulation late onset one, if the embryos are transferred in the index cycle. However, if you defer the embryo transfers, the incidence of also severe ovarian hyperstimulation syndrome is almost nil. More than, since we are on E2, more than the absolute value, it is the rate of rise of E2 in the last 2 days, which is very important. In the last 48 hours prior to trigger, if the E2 has been rising exponentially, this patient is more likely to go into OHSS rather than the absolute value that would indicate. Next. Do not trigger ovulation with the intent. Counsel the patient that in this particular, for you, the embryos will not be transferred in this particular cycle, though it will be frozen for the sake of the chances of ovarian hyperstimulation syndrome, which could be a life-threatening or other, which will be a dangerous condition. And that's the reason you will not be transferring the embryos, but you will be freezing the embryos if the patient has a high degree of PCO. Next. Antagonist protocol is the only protocol where you can trigger ovulation with agonist, avoid OHSS completely. It is the only protocol which can be started in the time-sensitive situations such as oncofertility, and it is the only protocol which can be started in the dual stimulation protocols. Next slide. Comparison of antagonist and agonist protocols. A meta-analysis of 45 randomized controlled trials involving some 7,500 women comparing GnRH antagonist and agonist protocol showed no difference in the live birth rates, no difference in the ongoing pregnancy rates, but a significant reduction in ovarian hyperstimulation syndrome rate, significantly lower consumption of gonadotropins, and more patient compliance. Next slide. Yeah, this question has been asked to me very frequently, Does oral OCP, oral contraceptive pill pre-treatment, impact ART results? Several meta-analyses of randomized control trials do not support the view that it causes any difference on ongoing pregnancy rate or live birth rates. There had been occasional papers by Y and others in 2016 or 17 which stated that it might affect it will, in their series, it affected live birth rates. This was in 2016-17, but a wonderful paper by Garcia Velasco in 2018, which had a larger database, and he went on to show that OCP pre-treatment does not impair the live birth rate. Next slide. So what are the determinants? As I said, we'll come to the determinants of the ovarian starting dose of the gonadotropins. The main determinants are age, BMI, AMH, day 2 FC, and response to the previous ovarian stimulation, if at all available. Next slide. Here I would like to touch upon one important topic, that is individualized controlled ovarian stimulation. Individualized controlled ovarian stimulation takes into consideration all the 5 parameters which I told you, and taking this into consideration, we tailor the starting dose of the gonadotropins in such a way that we optimize the usage. The word maximization has been replaced by optimization, thereby meaning that we reduce the cycle cancellation rates as well as excessive response rates, but get as many number of oocytes as dictated by the age and other markers of the patient to get a successful pregnancy. Next slide. Aims of the individualized controlled ovarian, I already told you, to prevent cycle cancellations in a young patient, to get around good mature oocytes up to 10 to 15 good oocytes, optimize embryo quality and live birth rates, reduce physical, psychological and financial burden of the patient, and the word maximization has got replaced by optimization. Next. And then there are various very complex models have been developed depending on even the consort algorithms have been used. But simplistically put, I always tell my junior colleagues as well as my fellows, age less than 35, AMH between 1.5 to 4, day 2 antral follicle count up to 20, average BMI starting dose should be around 150 international units, whereas age more than 35, AMH around 1.5 or less, antral follicle count less than 6, high BMI starting dose should be around 300. And then there are various combinations depending on the various results of the various tests and age profile of the patient that determine the starting dose of the gonadotropins. Next. Now, coming to the very important point of trigger options. Trigger is something which we give for final follicular maturation causing ovulation, and after ovulation, resumption of the meiosis for primary oocyte to be converted into secondary oocyte. Next slide. Basically, there are 4 triggering options: HCG, which is used as a surrogate for LH, agonist trigger, and the combination of 2, that is dual trigger and co-trigger. We'll see each one by one. Next slide. Again, next slide, same thing. HCG trigger, LH and HCG share 80% of their molecular similarities to the extent of 80% of the structure. But HCG has a long half-life and has a prolonged luteotrophic effect, which activates multiple corporal lutea and they sustain for a longer time. Next slide. Disadvantage as there is a long half-life, it maintains the stimulated corporal lutea for the longer time. And the most important disadvantage is that it is the HCG is the molecule which causes the release of vascular endothelial growth factor, VEGF, which is the molecule implicated in the causation of ovarian hyperstimulation syndrome, which leads to increased vascular permeability, escape of fluid into third space, and new angiogenesis. Remember one thing: no HCG, no OHSS. Next slide. This question again has been asked to me. There are 2 questions here are asked to me again. Whether recombinant HCG or a biological HCG will prevent. Both have the same propensity to cause ovarian hyperstimulation or normal stimulation. There is no difference between whether you use recombinant FSH or whether you have a recombinant HCG or a biological HCG, or whether one should use 250 microgram or 500 microgram. Again, there are no difference in the ART outcomes. In one of the prospective RCT, which consisted of 1050 cycles, you can use both I prefer to use 250 micrograms. For patients less than 60 kg weight and patients more than 60, I prefer 500 micrograms. Next slide. GnRH agonist trigger, how does it work? Through the endogenous release of both FSH and LH by agonistic flare effect of the GnRH agonist, which remains for about 4 days and then subsequently it blocks the receptors. It is more physiological because both FSH and LH surges are seen, which is seen in a normal, as if you see the physiology of normal ovulation, we have not only a surge of LH, but we have a surge of FSH also. So it is more physiological than the HCG trigger. Next slide. Agonist trigger has a downside also. Deficient luteal phase it causes because after 4 days it blocks the pituitary receptor. So if you are planning an index cycle transfer, you have to have aggressive luteal phase support with E2 and progesterone, and therefore you should. That's the downside. Next slide. Next slide. (2011) Cochrane review says if aggressive luteal phase support is not given, then the pregnancy rates are definitely lower. However, most importantly, it does not impact the quality of the oocyte, quality of the embryo, and it's an excellent trigger option that has eliminated the PCOS completely and is very useful for egg donors, PCOS cases, and high responders. Next slide. How to judge? Once you give an agonist trigger, you have to judge. We always judge the adequacy, both in my private as well as at Wadia. We've judged the adequacy of the agonist trigger by doing serum LH after 12 hours. And if the serum LH is more than 15 milli international units per ml, that is supposed to be adequate trigger. However, if the figure is less than 15, we inject the same dose of agonist. We normally use leuprolide acid 2 milligram and carry out the oocyte retrieval 34 to 37 hours after the first injection. Next slide. That is how we I already stated how to rescue the suboptimal agonist trigger. Next slide. Dual trigger. Dual trigger is a combination of leuprolide acid 2 milligram and SCG 1500. It still requires an aggressive luteal phase support to be used very judiciously when you have a number of expected mature follicles less than around 15 and still you are contemplating an index cycle transfer. It has an advantage that it takes care of occasional suboptimal effects of agonist trigger. It is to be deployed in very select cases, but remember, it still has a small chance of ovarian hyperstimulation syndrome. Next slide. What is the difference between dual trigger and co-trigger? Co-trigger was a wonderful idea that was developed by Professor Paul Devroy from Brussels. Here, it consists in administering SCG at the time of oocyte retrieval in a patient who has been triggered with agonist alone at the time of first trigger. Typically, the SCG dose is 1500 international units. It exerts effects on the corpus luteum, tries to rescue the luteal phase, but still requires an aggressive luteal phase number 1 and still carries a risk of small risk of ovarian hyperstimulation syndrome. Next slide. Who are the candidates for co-triggering? I have already stated those who are having number of mature oocytes less than 20, however, still need aggressive support, has a small chance of OHSS. Next slide. So we are in the era of OHSS preclinical, and it should be the goal of every assisted reproduction treatment center to be a OHSS free center. We achieve it by understanding the biology well, by using the drugs differently, and by adopting innovative strategies. Next slide. There are two forms of OHSS just to mention. The one which occurs up to first 9 days up to oocyte retrieval, normally a milder form and does not normally require hospitalization. The late onset one is the one which is in question, which causes maternal morbidity, the woman's morbidity and mortality. And that is the one which is caused by conception cycle because of endogenously produced HCG after implantation. Next slide. This is a wonderful data from Society of Assisted Reproduction Techniques, United States, for a 25-year data from 1984 to 2008. Maternal, the patients walking in for IVF, the mortality rate for IVF patients was 30 per million from 1984 to 2008, and those were the days where the long agonist protocol was used almost exclusively. Next slide. Next slide. It states the same thing. Is GnRH agonist triggering an option? A search, PubMed search showed 83 publications, and all of which concluded gonadotropin releasing hormone agonist triggering was the effective way to eliminate ovarian hyperstimulation syndrome, and that was what they stated. Next slide. This was another study. This was a wonderful paper by Peter Humayden in the Reproductive Biomedicine Journal. It consisted of a prospective RCT of 1,200 patients who had more than 25 follicles on the day of trigger. He triggered them with agonist trigger, froze the embryos. There was not a single case of ovarian hyperstimulation. It was mainly this Peter Humayden's paper that tilted the scale in favor of agonist trigger in antagonist cycles. Next slide. This is the picture of endometrial biopsy in a natural ovulation cycle. You still do not see a secretory changes here. Whereas, next slide, you see a clear secretory features in endometrial biopsy on the day of oocyte retrieval in a GnRH agonist triggered gonadotropin antagonist cycle. Next slide. Some of the latest concepts in therapy. The entire goal of assisted reproduction treatment has shifted from more than a decade and a half now, from achieving a successful implantation to achieving a single normal means structurally normal term infant. The term maximization has been replaced by optimization. Every ART clinic should be aiming to achieve a 0% OHSS rate, or it should be OHSS clinic. This is almost 100% achieved by the brilliant concept of segmentalization of the IVF cycle, which was proposed again by none other than Professor Paul Devroy from Brussels. Next slide. It consists in dividing or segmentalizing the IVF cycle into two parts: stimulation with antagonist protocol and agonist trigger, creating the embryos but not transferring them in the index or autologous cycle, cryopreserving the embryos, and subsequently transferring these embryos into hormonally prepared uterine cavity of the woman, thereby reducing the ovarian hyperstimulation syndrome to 0, no matter whatever be the degree of ovarian polycystic ovarian disease the patient has. Next slide. OHSS is a fatal complication, iatrogenic complication. Imagine a patient walks into the IVF clinic with the idea of taking home the baby and then lands up in ICU with protein drips and pleural and the third space tappings, etc., etc. This is something which needed a solution, and we have achieved it by segmentalizing the IVF cycle into stimulation part and transferred part, separating from each other. Next slide. There are small incidences of early OHSS that do not require hospitalization. Next slide. Even the small incidents can be at my centers. We avoid even the small incidents of a patient where we have aspirate more than 25 follicles by giving IV calcium drips for 4 days, right, starting from the day of oocyte retrieval. Next slide. Next slide. And the protocol is IV calcium 10 ml, 10% solution in 200 ml of normal saline, infused over 20 minutes every day for 4 days consecutively. Next slide. VEGF, as I said, is the molecule incriminated. VEGF receptor antagonists, type 2 receptor antagonists are being developed, and we will get them soon, which will be a very effective treatment for ovarian hyperstimulation syndrome. Next slide. Dopamine agonists, that is cabergoline, we routinely give in these patients from the day of trigger to prevent it. So also we give metformin from the day of trigger to prevent even the early and the small, because we freeze the embryos. So even the early OHSS we do not want, we give cabergoline as well as metformin in these patients. Next slide. So conclusions. In the past, we used to downregulate with GnRH agonists. Today, we start with antagonist protocol. We used to give in the past HCG for final follicular maturation. Nowadays, we give agonist for final follicular maturation. In the past, we used to do index cycle transfer with a OHSS rate of around 2%. Here we freeze all, transfer them in the next cycles with OHSS rate of 0%. Next slide. So what is the difference? Optimization of stimulation, we use GnRH antagonist protocol with agonist trigger. Optimization of embryology, that is by freezing the embryos, and optimization of endometrial preparation by transferring the embryos in the hormonally prepared endometrium in the deferred cycle. Next slide. So take home messages: use of antagonist protocol with agonist trigger, segmentation of IVF cycle into 2 parts as I stated, embryo transfer in the frozen embryo transfer cycle, prevention of even the small risk of OHSS by the strategies as I mentioned, identification of patient at the risk of developing OHSS by ovarian reserve tests, and the history of previous stimulation if available. Next slide. As I said, the yardstick of success has already shifted. Next slide. What are the future directions? In vitro maturation is the future direction. In vitro maturation is the future of PCOS. It definitely has 100% OHSS free propensity, no doubt about that. It consists in giving small doses of FSH starting from day 3, continuing for next 7 to 8 days, that is day 10, 11. When the oocytes are around 12 millimeter in size, the trigger is given with the HCG of 10,000. Next slide. This is the slide detailing IVM, which I have already just stated. All the oocytes aspirated are at the germinal vesicle stage, that is GV stage. Next slide. The period of in vitro maturation is anything between 24 to 48 hours, not yet finalized. Thereafter, the ICSI is done on these mature oocytes, metaphase 2 oocytes, and one initial study showed a maturation rate of 64%, fertilization rate, I am obscured by the slide, I think it is 45% after ICSI, and the live birth rate of around 7%. However, it has challenges. IVM is a challenging technique because it requires very optimum and up-to-date laboratory conditions and expertise on the part of the embryologist. It also requires exceptional skills on the part of the clinician to retrieve oocytes from those immature sized oocytes rather. Next slide. At the moment, there are no randomized control trials, so there is nothing to, we can still say that IVM is still being almost non-existent treatment or being tried at very highly evolved centers, and we don't have an RCT to prove that IVM is superior to antagonist protocol and agonist trigger and freezing the embryos. Next slide. So again, now I conclude with this last slide. PCOS and assisted reproduction, final conclusions. PCOS patient is the most difficult to treat with IVF. Cycle cancellation rates, ovarian hyperstimulation syndrome used to be higher with the long agonist protocol, but they are now with the antagonist protocol, they are almost nil. Pregnancy rates in women with and without PCOS are similar. This suggests that the implantation is not affected by the state of being PCOS. Fine tailoring of ovarian stimulation is necessary to avoid complications. Antagonist protocol with agonist trigger, freezing the embryos and transferring them in the deferred cycle is the treatment of choice for preventing OHSS to almost 0%. And IVM as a technique is a technique of promise, but it requires a lot of research still to be done to be deployed routinely into the clinical practice. Next. And with that, I conclude my talk. Thank you all for logging and listening to my lecture. Also, I thank Dr. Amit and Emcure Pharmaceuticals, as well as my colleagues, Dr. Chaitanya and Dr. Sonal, for having with us a lovely webinar. We are all ready now to take the questions, Dr. Amit.
Yes, sir. Yes, sir. So there are actually 50 to 60 questions waiting for all of us, but let us take it one by one. Thank you. I was going to request Dr. Sonal and Chaitanya sir to come online. I'll take the first question. The first question is, what is the cause of central granulation and vacuoles in the oocytes? This is a question by Dr. Anita Chigurapati. central granulations and vacuoles in the oocytes.
Right.
Causes.
You have to say that this is not a relevant question.
I think question should be relevant to the talks. It's not. It's an
Right.
embryologic question. Nobody will answer like.
Okay, no problem, sir. We'll take another question by Dr. Neena Gupta. For FET cycle, sir, what is your preferred MNC or HRT?
That question is to me.
Yes, sir.
In a PCO patient, the modified natural cycle is out of question because she doesn't have a natural cycle. See, the natural cycle and modified natural cycle embryo transfer are basically restricted to a very small subset of infertile patients who are normogonadotropic and normo-ovulatory. In PCO patients, it is definitely, as Dr. Chaitanya said, the question should be pertinent to the topic. So I am taking in the context of PCO patients, it will always be in the hormonally prepared cycle.
See, I think what she wants to know is that what you give in an FET cycle. So what you should give, estradiol 2 milligram 3 times a day should be given. It should be given minimum for 12 days. And then you observe the vascularity of an endometrium. Once the vascularity is zone 3 and 4, then and then only start the progesterone. Please don't start the progesterone. You can give from 12 onwards up to 28 days estrogen is allowed to be taken.
Yes.
But once you get the vascularity in zone 3, then you start a progesterone in the evening. That will be day 0. Then day 1, 2, 3, 4, you can give vaginal cream or vaginal tablet along with the subcutaneous injections. And day 5, you can do a blastocyst transport. That is the most ideal regime for the artificial cycle.
Right.
Yes.
Thank you very much, panel, for helping with this answer. One question by Dr. Karthik Savalia. He directly goes to Dr. Nagori, sir. There are 2 questions. One is, which protocol you use in your practice for IUI in PCO patients? Second question, dose and dosage of steroids, if and its role in IUI.
See, there are 2 things. One thing is letrozole plus gonadotropin is an ideal combination. You start from day 3, 4, 5, 6, 7. Letrozole 2.5 milligram is given. And day 7 or day 8 onwards, you can start gonadotropin to the patient. Now, depending on the AFC, if the AFC is more than 25, then you can start with 37.5. Otherwise, you can start with 75 international unit. Give it for 5 to 6 days. Once again, you can do a scan. Continue the same dose until you get a single 1 or 2 follicles. That is our most ideal dose. And in those patients, particularly those which are PCO patients, which are resistant patients. So these are the cases where the androgen level is high, and these are the cases where you give dexamethasone 0.5 milligram continuously for 30 days, and you can give it for 3 to 6 months also. So dexamethasone will reduce the dose of gonadotropin, it will reduce the dose of oral ovulogins also, and it will help the pregnancy rate.
Great. Thank you very much, sir, for the answer. One question directed to Dr. Sonal ma'am now. Dr. Preeti is asking to Sonal ma'am, can you explain again what do you mean by USG criteria not used for diagnosis of PCOS before the gynecological age of 8 years, ma'am?
Yeah, so since in the young age, in the 8 years of gynecological age, that means 8 years after the menarche, we know that the ovulation is not regular, the cycles are not regular, these patients are likely to have multicystic ovaries, and therefore in these cases you cannot use ultrasound criteria, that is multiple follicles, as one of the 2 criteria to diagnose PCOS. Because otherwise we say just 2 criteria out of 3, that is oligo or anovulation, hyperandrogenism, and ultrasound PCO ovaries. So if only 2 are present, we otherwise in adulthood say it is a polycystic ovarian syndrome. But if it is in the adolescent age, which is 8 years after the gynecological age, so 8 years of gynecological age, during this period, the patient has to have ultrasound ovaries on PCO, oligo or anovulation, and hyperandrogenism. Only then you can say the patient has PCOS.
Great. Thank you, ma'am, for that detailed answer. Fantastic. One question again to Dr. Rajan Vaidya, sir, from Dr. Jaya Vishwa Balaji. Sir, what is the dose? What is the dose of trigger for low? What is the dose of trigger for low dose gonadotropin IUI cycle? And at what measurement of follicle will you give the trigger?
It should go to
Yes.
Chaitanya.
See,
Acha.
it is always either you can go with 10,000 international unit of HCG urinary highly purified, or you can go with 250 microgram of recombinant HCG. You can give it. Now we always rely on color Doppler. We don't depend on the size. Once we get the RI between 0.4 to 0.5, and when the PSV is about 10, then and then only we give the trigger, and we do IUI after about 36 hours. So, particularly when you are going with chronic low dose protocol, then you will not get much follicle. 1 or 2 follicles will be there.
Okay, thank you, sir. So one question on ovarian drilling, a very interesting one by Dr. Sujata Jyoti. She's saying, can you grossly say how many puncture based on AMH in case of ovarian drilling, since we have only 2D ultrasound?
See, AMH will not tell you the fee, that it does not tell you the severity, but and you cannot demarcate. It is according to the stromal volume. So you have to know, and particularly if it is you have diagnosed PCO by insulin resistance, then you should completely cover the anti-mesenteric border of the ovary when you are doing a drilling. So rough calculation will be according to the size of the ovary, between about 0.5 to 1 centimeter distance. You should go on puncturing with the monopolar cautery, that is unipolar cautery. You should use it, and then at the equidistance you should, on both the lines, 2 lines on this side, 2 lines on this side. If you cover, that will be an approximate number of punctures which will be required for the ovary.
Great.
If you don't have a 3.
Acha. Thank you for this detailed answer, sir. So Dr. Rakshita is asking one question. After LOD, when do we do AMH levels?
1 month. After 1 month, you should go for an AMH.
Okay. Dr. Isha is asking, antagonist usage in IUI cycle in PCOS patient. Please share when to start. Does not it affect endometrium?
See, particularly when the size of the follicle is 14 millimeter, then the chances of premature LH surge are very common. So when the size is about 14 millimeter, then you should start an antagonist till the day of HCG.
Okay.
So once the follicle is mature and you are going to give HCG, up to that day you should give an antagonist.
Okay. One question to Sonal ma'am from Dr. Kaushik. How to measure ovarian volume in 2D scan?
As I had described already on the presentation, you first locate the ovary. Once you have located the ovary, you'll rotate the probe and find out the longest axis of the ovary. On that longest axis of the ovary, you can scroll across and find out the longest diameter. You have to freeze that image and you measure the longest diameter. On the same image, you take another diameter which is perpendicular to that long diameter and the longest one. So longest long diameter, a longest diameter perpendicular to that diameter, and then you rotate the probe 90 degrees without any other movement. That will give you a transverse section of the ovary. On that, measure side to side measurement, that is your third diameter. So these are the 3 diameters.
Okay, great. Thank you. One question will go to Dr. Rajan Vaidya sir again. In CC stimulation for thin endometrium, what to be done?
Right. No CC.
Again, it goes to you. He writes your name. Please, sir.
No CC in a thin endometrium. Why do you want to use CC? You can go to other drugs. And second thing is, estrogen has got no role as far as the endometrium is thin in the CC cycle.
Okay. One question goes to Sonal ma'am again. At what level you keep PRF and gain setting during color Doppler?
The gain settings need to be varied depending on what model you are using. The PRF setting is always set at 0.3. The gain settings are so done so that the color doesn't spill out of the blood vessels and the entire blood vessel is filled with color. So that is your gain setting. The third setting which is required, which you have not asked for, is the wall motion filter setting. And the wall motion filter setting for all your stromal flows has to be lowest. And if you take into numbers for the spectral Doppler, it is 30 Hertz.
Okay, great. Sir, there is a question for Rajan Vaidya sir again. Sir, can you again explain co-trigger and dual trigger?
Yes. Dual trigger is the one where both the triggers are given at the same time. Whereas co-trigger is the one where you trigger with the agonist first, and on the day of retrieval, you follow it up with the 1500 international units of HCG. The dual trigger is supposed to be given when you are not sure about the adequacy of the agonist trigger to circumvent the suboptimacy of the adequacy. Whereas the co-triggering is done when you feel that on the day of oocyte retrieval, the number of the picture of the number of follicles which you have retrieved, the oocytes you have retrieved, are less than, say, a particular figure of 12 to 15, and you can go ahead. Endometrium is favorable, and you can go ahead with the embryo transfer in order to rescue the luteal phase to some extent. You can go ahead with the triggering. So basically, it's a difference in the timing. Dual trigger is at the same time. Co-trigger is the sequential one, where you give agonist first and the HCG trigger follows at the time of oocyte retrieval.
Okay. Okay, great. Thank you, sir, for that explanation. A doctor is asking again, if FSH is 7 and LH is 10 on day 3, can we start stimulation in same cycle?
FSH is 7 and you're talking
LH
FSH
is
7.
10.
FH, yeah, sure. We start LH in the random start the luteal phase protocols. I would, if LH is already reached 10, I would still go ahead with the stimulation. Give her a. I would still find out. Is it a fresh cycle?
He has not mentioned
Is it a
all
dual
about that.
stimulation? If it's a fresh, I will answer that. If it's a fresh cycle, I will straightway abandon here. I will put her on OCP for about 20 days and then take her up for stimulation with the recombinant FSH straightway. Whereas if it's a dual stimulation or in the random start where there is already a corpus luteum there, just ignore the LH, give her a luteolytic dose of antagonist, which is normally 1 milligram at the time of recombinant FSH. I give the luteolytic dose of antagonist for 3 days. We very commonly do oncofertility. In oncofertility, we do these luteal phase random start stimulation protocols. And there have been so many papers which have now proved. The Michael Rosen's paper in 2015 published in ASRM states neither the elevated luteal phase LH nor the elevated luteal phase progesterone have anything to do with the oocyte quality as well as embryo quality.
Hello. Hello. Yeah.
Was I heard?
Yeah. Thank you, sir. Next question for Nagori sir is there. How much will be the changes in PSV and RI if we are doing scan in morning and trigger to be given in night?
I think that is my question probably.
The doctor has mentioned in that Nagori sir's name. That's why.
It's okay, not to worry,
Okay.
because it's an ultrasound question.
Okay.
If in the sense you mean to say probably that how much would be the PSV and RI in the morning if you, and you would plan a trigger in the evening. The question is that generally the PSV increases on the last day by about 0.5 to 1 centimeters per second in about 8 to 10 hours. So if the PSV is about between 8 and 9 and the RI is less than 0.5 in the morning, you can give one more gonadotropin and plan a trigger in the evening. If it is a CC cycle, you have to wait for the next day. But if the PSV is less than 8 and if the RI is more than 0.5, you don't give a trigger on the same day.
Next day.
In scoring chart, it is volume of one ovary. If it is volume of one ovary, AFC is total. What is the total AFC? It is question.
AFC, whenever it is written, it is both the ovaries together. If it is a single ovary number, if it is the number of follicles in a single ovary, it's always written as FNPO, follicular number per ovary. In the chart, ovarian volume is the mean ovarian volume of the two ovaries.
Okay. Rajan sir, the question is for you. What is the protocol you use for endometriosis?
Endometriosis with IVF.
Yeah, Dr. Rakshita has.
Yeah, though it is not related to today's topic, I will straightway answer. My protocol is antagonist protocol, whatever be the indication for the IVF. I would definitely go for antagonist protocol.
Okay. There is one more question. Is there any role of giving antagonist in freeze all cycles to prevent PCOS?
Is there any role of?
Is there any role of giving antagonist in freeze all cycles to prevent PCOS?
Not to prevent PCOS, to prevent OHSS.
Okay.
Because that's the mainstay of the lecture was on antagonist and this thing. Antagonist protocol, agonist trigger.
She wants to tell that can we continue antagonist for the prevention
Yes.
of an OHSS? But if you have given an agonist trigger, then there is no question of continuing antagonist. There is no need of it.
Not necessary.
Nagori sir, next question to you is, what is the role of OC pills in patient of PCOS with high LH? For how long OC pills has to be given?
See, OC pills in an IUI cycle, you can give it for 2 to 3 months and that decreases an LH level. But because now the antagonists are available, we don't use OC pill. Those patients who cannot afford gonadotropin, you cannot afford an antagonist because that will all increase the cost to the patient. So those patients who are very poor coming from villages, what we do, we give OC pills for 2 to 3 months, but that will decrease an LH. Where before the antagonists were available, we always used to give OC pill for 3 to 4 months to the patient. That decreases an LH, and then your oral ovulations will be very effective at that time. But now we don't waste that time because we can decrease an LH by giving an antagonist to the patient.
Okay, sir. Sir, next question is also to you, Nagori sir. Do you prefer any pre-treatment adjunct for PCOS like myoinstall, vitamin D3?
Absolutely useless as far as infertility is concerned.
Okay. How to calculate ovarian volume?
That is, she has already said, na?
If it's on 2D, I've already described the three diameters, X into Y into Z into 0.5.
I think it has been taken, ma'am, by you. Well taken by you. That those three. How many days would you would give antag and dose in random start?
How many?
How many days you would give antag and dose in random start?
That's a good question. We give it 1 milligram subcutaneously daily for 3 days, right from day 1 of stimulation in a luteal phase.
And sir, how much antagonist to be given to suppress?
1 milligram. That is 1 milligram is 4 times the standard dose of antagonism.
Okay. I think we have taken most of the questions we have taken in this session, sir. And I thank you all for giving fantastically all the questions, answers. I will just hand over this session to my National Divisional Head, Mr. Rajiv Agarwal. Over to you, sir.
Thank you, Amardeep. Very good evening. I am Rajiv Agarwal on behalf of MQ Pharmaceutical. I just, with the bottom of heart, I thank Dr. Rajan Vaid, Dr. Nagori sir, and Dr. Sonal Panchal to have on the board of MQ. We are really privileged and honored. Sir, thank you very much. And I thank all the doctors who have joined this session and listened patiently to you. I thank my team for making this webinar very successful. And in this difficult time of COVID, let us pray that very soon we'll come out from this situation. Till the time, we wish you stay healthy and safe. Thank you very much. Thank you, sir. Thank you.
Sir, we almost crossed 505 participants in this session, and we had many questions. And in between, Dr. Amit's computer was a little bit in fault. That's why I had to take this question answer.
Thank you very much.
Yeah.
Thank you.
Thank you.
Thank you. Thank you, sir.